we're really privileged to have two plenaries with Dr. Pam Jeffries from Johns Hopkins in Baltimore, who's here for the second time, and some of you would have heard her the first time, and that's why she's here for the second time, because she has so much to offer us. Dr. Jeffries is Professor and Associate Dean for Academic Affairs at Johns Hopkins School of Nursing, and is nationally renowned for her research and work in developing simulations and online teaching and learning. At the Johns Hopkins University School of Nursing and throughout the academic community, she's well regarded for expertise in experiential learning, innovative teaching strategies, new pedagogies, and delivery of content using technology in nursing education. And I want to share with you, for those of us who heard her before, Pam's done your work. Pam does your work. She is a nursing professor. She has been a clinical instructor and has walked those shoes and walks your shoes. And so it's a real opportunity to learn with her about what she's done as a result of her research. She has been principal investigator on grants with, oh darn, I fixed this thing, I touched it, with groups such as the National League for Nursing, and is providing research leadership and mentorship on national projects with the National Council State Board of Nursing. And of course, we're particularly interested in the national study and the work that Pam is leading around the shift of the mix of simulation and clinical practicum that is being dealt with by her research. Pam is an author, a researcher, a fellow that's been recognized by a number of professional organizations in the United States in nursing and in simulation for the contributions that she makes. She's a very busy lady, and I want to say a personal thank you because we did talk over many months. Could you come? Yes, I can come. But then life changed. Can I still come? I don't know. Well, she is here because she sandwiched us in today with a flight this morning, coming back right after, and we have chauffeur service with Lisa Ann and John Richards, because life changes in her situation too. But she's here to share with you her learning, her experiences, her ideas for our benefit in two plenaries, and I'm going to turn it over to Pam with your welcome. Now, you got one.
I'm double wired. Can you hear me okay? He's got two mics because it's being video recorded, as you said. So
I think I turn all this off now.
I think she can become unplugged, right? All right, and this is plugged in. All right.
So over to you.
Well, thank you for the nice introduction. And reason my calendar has changed, my dean is stepping down as of July 1st. And last night was her garden gala, and then tomorrow's another dinner. So this is a sandwich in, because I need to be there for all the celebrations and people retiring and this and that. And when we talk, they don't look at my calendar when they schedule these things, you know? So then I have to do some shifting, and we talked, and so I'm glad I got to come as well on a morning Air Canada flight, and we'll go back that way. So I'm very excited to be talking about clinical simulations this morning, where we are, where we're going, just some highlights. There's so much to talk about. In fact, I probably have too many slides. I do want to save some time for Q&A, and I speak right after lunch, another session, and it'll be more of an abbreviated session, so more time for Q&A after lunch, if that's okay. So what I would suggest that you just jot your questions down. How's that? And I will really make it a point, more so after lunch. I'm trying to set the stage now, because in our simulation world, there's tons going on. It's all very, very exciting, I would say, because of the nursing education revolution is what I call. And in the States, we have healthcare transformation, and I know you're probably always looking at quality improvement and all that too. So I feel it's a perfect storm with all of this right now. So very briefly, we'll talk about the prevalence of clinical simulations in nursing education today, talk about current issues and challenges in the research and future possibilities. Just so I know my audience though, how many in here are nurses? Just so I see, all right. How many are in here from the allied health sciences, like RT, OT, those, okay. Any physicians? Okay, any nurses from the practice world, staff nurses, staff educators, okay, because the practice side. Am I missing anybody I'm missing? And you're all academics mostly, except maybe the practice side, you're managers and directors. Okay, good, good.
And we have our CNO in Colleges Ontario and Ministry of Training Colleges and University and Colleges Ontario. So we got some of our other
Okay,
partners here.
good. Partners and leaders and regulatory, leaders from the regulatory board and all that.
And
All right.
Sim1 strategy group for the province.
Yeah. Well, it's fantastic to see the collaboration, honestly, and you come in cohorts like that. That's great because then you have support of each other. Well, a little bit about, and I'll talk about a big study that we did. This is in National Council State Board of Nursing. A couple years ago, as we embarked on this really big study that I think has policy implications and clinical education challenges. And by the way, do you have PowerPoints? If not, you can distribute or I can send them. So you don't have to.
Everybody has them.
Okay.
These are the ones you sent us?
Yeah, I hope so. If not, just wave your hand. Yes, I think so. Anyway, a survey was done, and I just show you this slide because there's many simulations being done. In fact, I got to go back. Actually, 87% of the schools of nursing across the United States had SIMs in that responded to the query, the survey that we sent out. And typically, just so we're all on the same page, and I'm defining a simulation as a clinical event or activity that represents clinical practice. So we're setting up a safe environment, whether it's in a learning lab, practice arena. Sometimes hospitals and schools of nursing are going together, or interprofessional medicine, nursing, allied health, all that. And we set up these rooms that replicate practice, and I've seen yours. I know you're doing the same thing. You immerse students into the simulation. We're doing 15, 20, 30-minute sims, not much. It's a snippet of something that's critically, that you want the student to go in, and typically we assign them the scope of practice, the RN, or they have orientee, whatever. And then the beauty part, after they assess, implement it, or take care of the problems, whatever the scenario is about, is that debriefing. And there's strong evidence where that debriefing is where the students are connecting the theory with the practice and the dots and all that. But a couple of things I just want to point out with simulations before I go on. One thing I like about simulations, because now in our education world, we're all educators, I feel we are going to produce different graduates than we have had before. And I'll speak more about that a little bit later. But now we've created this environment where we actually can immerse the student and see them problem solve, can't we? They can assess, they can intervene if you're watching through a one-way mirror or on video or whatever. We can see if they're putting it together. And if they're not, then we can talk about them in the debriefing and guided reflection. So that, to me, that's priceless. I don't know about your traditional education, but mine, when I've done clinical education and faculty keep doing it the same way, we've done it the same way for decades. Have you here too? I mean, we just never change. Yet everybody says we need to change. We're not producing the graduates you need, but yet we keep doing the same thing. So with simulations, though, in this safe environment, I feel we've created this area where we can immerse students, as I said, we can see them. But what's really important to me is that we immerse those students in their scope of practice. So they're practicing the role of the RM, where if you look in the educational arena, they're student learners. They're always student nurse. Don't they wear IDs that say student and all that? And probably as your instructors, you don't let, they can only do so much because you have to intervene, or you're always saying, don't forget this. And also, in some of our practice sites now, they say students they can't use the glucometer, they can't do blood sugars, they can't talk to physicians, they can't do this. So it's up to we as educators to bring that into these safe learning environments that we're creating, called simulation centers, spaces, all of that. And to me, that's priceless, because now we're developing a new environment and territory for our nurses, students. But anyway, with that said, I watched a student once in debriefing, and she was managing a room or a complex patient with a dynamic family that I think, anyway, she had a lot going on. And in debriefing, and she was the person that played the RN, in debriefing she said, I just wanted to call for the RN. You know, she is the RN. She's getting to be in that role. Where, think about it, in the States, after our students take their state board, the NCLEX test, then they magically become RNs. But they've never practiced the role of an RN, but yet we have high expectations that they know what this is and that they can do that. That's that bridge, that's that gap we're not bridging that very well. But income simulations, I think that's really going to help that. So we're doing a big study. I'm going to talk to you more about it, but many of the programs are doing sims, not only in the clinical, but sometimes in this large classroom. We've got simulations going on in theory classes because with the technology, there might be a simulation going, say, care of the pneumothorax patient, chest tubes, all that. Instead of the instructor talking about it for 15 minutes, she'll show a simulation, maybe live, it could have been videotaped, and then the whole class debriefs. What went well, what didn't? Bring the students in, let's talk about it and debrief. So everybody's engaged and we're using the sims in the classroom. I said 87%. The other, across schools of nursing that were surveyed, and I imagine that number's higher now. It's probably between 90 to 100%, somewhere 95 to 100. The other piece I want to just tell you though, so you've got a clarity here. Across 50 states, we're all regulated by a state board of nursing, and they're all different. And then we have a national council of state boards of nursing in Chicago, but there's 50 different states that do things differently. 2 states, California and Florida, have said, nursing school leaders, faculty, you can substitute real clinical time with 25% of simulations. So, for instance, instead of 100 hours of real clinical, we can do 25 hours in the lab, simulations, replicating clinical practice in 75 in those 2 states. They've drawn a line. But you can do 10 or 15%. They're just saying the max is 25%. And that's okay, but I got to tell you, there's no evidence that that's good or bad. There's just no evidence. And that's what the National Council study I'm going to talk to you about in 20 minutes is about, because we want to know, can we do this or not? Because there's lots of skepticism. I work with faculty that you all do. They're either on board or they're not on board. They think it's got to be the real clinical. And I got to tell you, get in the literature of real clinical education, that's the gold standard. There's hardly any research on it. I don't know if you've been in the literature. I've been in the literature. I can cite some of it yet today or this afternoon. And we already know from nursing leaders, organizations, we're not preparing the graduates we need. Yet we as educators for decades keep doing the same thing because we don't have any good models, I guess, or hesitant to change. So those 2 states have drawn the line, say 25%. One state, Ohio, Midwest, says you can't substitute any. You can supplement, you can enhance, but if it says 100 clinical hours in your clinical, you're going to have 100 clinical hours. And then the SIMs are going to have to come in some enhancement. But that leaves 47 states that are watchfully monitoring. They're saying, go ahead, incorporate. In fact, we've got some, and I'll tell you some examples. At NYU in New York, they're substituting 50% for adult health because of a faculty shortage and all that, but I'll get into that in a minute. So what I'm trying to paint the picture, we vary across state. Simulations are going strong. Financially, sim centers, it's made an economic impact. Sim centers are being built not only locally, but regionally. There's statewide consortiums like in Florida, in Oregon, there's statewide. And then internationally, they're all over. Been to Singapore, been to Switzerland. Everybody is moving to sims, and I mean that in a general sense. So it's here to stay, and we just want to get it right and what are the best practices and the outcomes. So the other impact that's changing is, I believe, moving us toward a simulation-based curriculum, which at Hopkins we just adopted, and I'll tell you what that looks like in a minute. But we had Institute of Medicine, we call it the IOM report, went with the Robert Wood Johnson, and they developed what's called the Future Nursing Education. Has anybody seen that? You can download it if you Google that on the web. But there was a think tank of blue ribbon panelists, nursing leaders, all that. I actually served on the panel for simulations and technology. But they brought people together in a big forum, and public could come and say, you know, where are we going with the future? What do you see? So at this summit, then it was written up here with recommendations. And that report, I must tell you, is driving a lot of what we're doing because people go to the report. For instance, part of that report says by 2020, we will have, how'd they word it? 50% of our, I can't even quote you accurately, 50% of our we will have 50% more doctoral prepared faculty than we have now. So whatever the baseline was at that time, we're going to get more. But of course, we've started what's called the DNP, Doctor of Nursing Practice, and we've got the PhD. We have 2 doctorates. Do you have DNP here? Doctor of Nursing Practice. That's a clinical practice doctorate. So a lot of our advanced practice nurses, NPs and all that, they're moving into the DNP because it's a practice. It's about quality improvement and all that. Then we have the PhD, more about development of new knowledge, the science, all of that. So also that report's saying we're going to increase our baccalaureate prepared nurses because in the States, unlike you, which I applaud you, I think you have established an entry to your practice. And we have not. We're all over the place. We have 2-year, 3-year, 4-year. And for decades, we have talked, and it's not changed. Now more of our conversations in the States about these doctorates. So it's shifted from the entry to practice to more about this. Will we ever solve anything? Probably not. People just talk and talk about this. But what's driving, though, our market, this entry to practice, I think what you're going to find, and I'm just giving you the landscape. Some hospitals now are only hiring baccalaureate prepared nurses. So that's driving people saying, well, maybe I better get my bachelor's versus an associate or diploma. Or if some are hired, then the hospital's saying, then in 3 or 5 years, whatever they say, that you would have your bachelor's. And there's all kinds of community colleges now with articulation agreements with university baccalaureate programs to build them into the baccalaureate. So I just wanted to paint that picture. Secondly, part of this report, and I just want to share that with you, down here, it says nursing students will be required to demonstrate comprehensive clinical performance competencies. This is what's being recommended currently in the States for graduate students to become RNs. They take the NCLEX, that's the State Board of Nursing. It's a computerized exam. And after they get a license, they practice nursing. But there's no competency testing. Doesn't mean they can do a sterile dressing change or know anything. It's a written test. Is that what you do here too? But I think the handwriting's on the wall. That's why I point that out. With all these simulation centers and all that, I think we're going to start, in the future, there'll be competency testing. I'll call it high stakes testing. Before a student becomes an RN. It's just like in medical education. They have the OSCEs, Objective Structured Clinical Exams, they go through, and they have 12 different stations, and they have to pass these, to get this certificate or license or whatever. I think it's going to be moving to that because we have the facilities, and also, just like you, we have this culture of safety, the whole patient safety movement. We've got to change things. It's no longer acceptable if you're not competent or not performing accurate care. So simulations, here we are, just a little bit about the research. Just wanted to let you know that through nursing, medicine, both the bodies of literature, or in aviation, we get into all the literature. But it was Dr. Bill McGahey and all, they did a critical review of simulation-based, even though it's medical education, it's for all of our healthcare professions. And the reason I bring this up to you because they outlined 12 best practices in simulation. So you can read this on your own time. But you can see feedback is really important. That's when we have that guided reflection. It's so important. If students don't know what they're doing wrong if you don't tell them. And personally, in real clinical education, when I'm chasing around 8 students, I don't see what they all do you? And in our clinical education, just see if it's similar to yours. If I have 8 students, I'm with you for medications, you for a Foley cath, you for tracheal suction. By the end of the day, I've only done psychomotor skills with students, ensuring that they've done them safely. But I haven't had time to talk about the complexity of the healthcare environment, the critical thinking, their planning, and what about. Unless we get in a post-conference, but usually everybody says, what'd you do, what'd you do? Okay, time to go home, And then it's done. Then that's our gold standard, that's our clinical. And luckily, students do learn, I mean, we're putting things out. But one other study that's coming out, and Johns Hopkins was part of that, along with Indiana University, where I used to teach, in Gonzaga University. It's over in Spokane, Washington. That study, and I don't have the results, but I've heard about some of the preliminary. We actually had evaluators go in clinical and watched how much interactions faculty had with students, how much time students spent with patients, how much time students spend waiting in the hall, waiting on faculty and not doing anything because they're waiting. Won't you be surprised about the findings? Some of the preliminary, and don't quote me, wait till you see it, it's coming, but we miss teaching moments all the time. And really students stand around waiting a lot because we're with them. Anyway, but how better you standardize and use simulations as part of that clinical time because you've got control over that. We can standardize it. So for instance, in adult health, if I want everybody to care for a diabetic patient that's hypoglycemic and they know how to do and look at the orders and all that, I've just accomplished a standard for care of the diabetic patient that maybe only 60% had in trying to bank on real clinical. By the way, I'm not trying to do away with real clinical. I am trying to market SIMs, I'll tell you. Or I'm just, I'm an advocate for them, but more and more I see I'm very much sold on them. In the literature also, I bring your attention to Cook and other authors. This was in JAMA, so a really high impact medical journal. And you can see they looked at 10,000 articles and the researchers got it down to 609. But what I like, and they pulled it to associate with, they pulled it to patient outcomes. And that's where we have to bring in the value of simulations. If we're doing simulations in educations, we think we're preparing better students, I can tell it. But hey, what about over here in the clinical? Are we improving patient outcomes? If we're producing a different graduate that's gone over, are our nurse quality indicators better when we have students or new grads that have trained on simulations? Are we doing better? That's where the research gap is. But at least this study said the effects using the simulations technology had a moderate effect on patient outcomes. So there's movement toward that, and that's where we must go. Also with that meta-analysis, they asked to clarify when should we be using simulations and how do we use them most effectively and efficiently. Because you don't have to do simulations for everything, but when should we be using them that we're going to get more bang for the buck, so to speak. Another one, this is the nursing, Schmick, Wu, they did a whole state of the science in pre-licensure looking at the HPS, the human patient simulator. And of course, what they say is we need more multi-site studies and more rigorous studies, more rigorous research. We all know that. If you get in the literature, some of you are probably working on your doctorate or master's or whatever, you get in, we still have, our research still needs to, it's an embryonic body of knowledge and science. We need to continue to work on that. And then I just want to mention the NLN work. We started back 2003. I was fortunate to be a director, and that's that simulation framework we designed, if you haven't seen it, but we built a lot. And that right now, actually next week, I go to Las Vegas. This simulation framework is being explored and examined by nurse educators in the society. It's called INACSO. Has anybody ever heard of that? International Nursing Association Clinical Simulated Learning. What a mouthful. But they're trying to move this to a theory. So in the theory, you look at relationship statements, and there's a whole science in that and how to do it. But that's part of, and this is how we develop simulations using this framework and these features. And people have tested it over and over. It's still working out well, even though that was clear back in 2003. Looking at the literature, it's based on 3 eclectic learning theories: the learner-centered, sociocultural, and constructivist learning theory. So at this time, I just want to talk a little bit about changes, issues in nursing, about the regulatory boards, partnerships, skill set changing, because there's much. So I already mentioned the boards are watchfully monitoring, and I'm going to talk about the study in a minute. I forgot what order I had them. And I already told you about the percent, but 47% of the states say yes, substitute. And I'll tell you at Hopkins, we just voted, faculty-owned curriculum, they voted, but we have what's called a simulation enhanced curriculum. And with that, we wanted to be strategic. And we're coming off the National Council study. We were one of the 10 schools that participated in that study. And to participate, we were doing high doses of simulations. And I'm going to get there because I have PowerPoint. I talked before I get to my PowerPoint. So anyway, I have faculty that are prepared in delivering and implementing simulations. So now it's key. So I went to faculty as the Associate Dean of Academic Affairs and says, what's your strategic plan? What are we doing here? Let's make a plan, a goal. Because you can't get resources unless you have a plan. But you can't study outcomes unless you're conducting it in an accurate, appropriate manner. So faculty voted to substitute real clinical time for up to 15 to 20% of the real hours with simulations. And that's across 7 core clinical courses. It's a Foundation Fundamentals course, Adult Health 1, 2, OB, Peds, Community Health, and Psych, Mental Health. And we've done that the past 2 years. We've done it across 7 core clinical courses. So we have simulations, we have teams that have been built to do this, and now people, they fight over sim rooms. Fight, that's harsh, but they have to schedule and take turns. Somebody might have to do evenings. Like last night, we were humming in the sim lab till I think 8 or 9 o'clock, because there's a pecking order, and if I do evenings this time, next time I'll do days, the regular clinical times, so people work together. But with that said, as an associate dean and doing budgets and all that, when they have 15 to 20%, as an associate dean, I need to give them resources. I need to give them the support to do that, because we've adopted that, and I support that greatly. So with that, now I can better plan. We need more mannequins to do X, Y, Z because of all these hours. And by the way, our hours are like 112 clinical hours for a 2 credit hour course. I don't know, you guys do credit hours. So you know the scope, 112 hours. So if you're doing 10%, that's 11 hours. It's a 1-to-1 ratio, 1 clinical hour to 1 sim hour. So up to 20%, that would be 22 hours. We're going to substitute out a clinical into the sim lab across the semester, across 7 weeks, whatever that looks like. But on the side point, there's been questions. I don't know if you had questions last hour. People are saying, is sim time equivalent to clinical time? Should that ratio be 1-to-1? That's a question mark. There's no evidence. People are doing it differently. We were just on a study with NYU, New York University, right in Manhattan. They're taking like 300 students at a time. Huge, huge. Anyway, they have a huge sim lab, and the study, Hopkins did the study with them because we were a comparative school. And what was being studied, NYU and their Adult Health 1 and 2 courses, they have substituted real clinical time for 50% SIMS. Every time, every adult health course. And the reason they did that, because of faculty shortage. They couldn't get enough clinical faculty to take students to clinical. So let me tell you their model. Again, I'm the messenger. I'm not going either way, but there's different models, and we have to study. And I see the researcher in here. You got to get the outcomes. Is it working? And we have the outcomes. It's working, by the way. But what they did, they have clinical Thursdays and Fridays. So now they have faculty assigned to 2 clinical groups instead of 1. Typically, I'd have 1 clinical group, and I go Thursday and Friday with these students to the hospital or wherever. Now they have a faculty, say Pam's assigned 2 clinical groups. So her group A on Thursday goes to the sim lab that's run by a sim team, and my Friday clinical group is in clinical on Thursday, or my group B is on clinical on Thursday. You switch it on Friday, my group A now is on clinical, and my group B, you follow what I'm saying? So now I have, I think, 16 students instead of 8, 1 to 8, because I've had 2, but the sim team's running the sims, the faculty's at the clinical, and then there's a communication plan, because the real clinical faculty don't see the students in sims. That's probably a barrier, but that's how they're working. And they have increased numbers in their programs phenomenally. They have prepared a sim team, they've expanded their sim center, and that model's working. And we've got, I'd be glad, it's going to come out, we're getting ready to publish it, but if you want more on that, I'd be glad to send you some information. Anyway, their ratio's 1-to-2. 1 clinical hours equals 2 sim hours. They think it's twice as intensive. Has anybody done an 8-hour sim day? You're exhausted, aren't you? Students are exhausted, faculty are exhausted. And again, I'm just giving you information. I'm not advocating either way, because there's no evidence on any of this. But NYU decided to define their simulations as 2 hours of sims equal 1 hour of clinicals, because it feels like it's spot on, it's intensive, they're on Every minute they're in sim lab. They're not waiting in the hallway for an instructor for 30 minutes to come and give them ed. They're spot on. So anyway, that's 1 to 2. My faculty had to talk about that. Are we going 1 to 1 at Hopkins? Are we going to go 1 to 2? What are we going to do? Question mark. They end up going 1 to 1 right now. They might change it because, again, there's no evidence. We need to study it. I would like to study it. I would like to do an outcome study on that. Does that make sense? All right. The other thing moving are these partnerships. No longer should we be doing this together by ourselves. This is huge. You guys, all this collaborative, 25 organizations represented. I applaud the leaders that got you together. If you've got sister schools you're near, you've got a hospital right out your back door, and you're an academic institution, you should be partnering. You can't do it alone. And give you some examples. I was a leader for a consortium in southern Indiana, but this was with hospitals, a large baccalaureate program, and community colleges. And we did get some grant funding, but it was about faculty development for simulations. There was no use to replicate something 10 different times at 10 different places. So everybody got together. And what was beautiful, the hospital folks got together with the academic folks. So they had to write sims. I trained them together. They wrote sims. They delivered sims. They debriefed together. They learned from each other. So when we're writing sims, though, instead of saying, oh, what am I going to write a sim for now? You ask the hospital people, and they'll tell you the top 5 errors occurring. Medication reconciliation, falls. I mean, they can go on and on. That's what we're doing sims on. That's easy. We incorporate it in our program, and the hospital has them for their new grads or whatever. So that's partnerships. I can talk about more and more, but even for grant funding in the states, no longer probably will funding be for one area, one school, one entity. They're looking at impact, big bang for the buck. Another consortium, this was in the state of Maryland. We did this with 13 different schools of nursing, community colleges, and baccalaureate. Something like here, your faculty development, you got 25 organizations here. We would hold this every January. I led that. It was a week instruction, and it was like train the trainer. So I had an advisory board of leaders from 13 different schools. We came, we picked the date, and then they go back and they can send 2 to 3 of their faculty to this institute. And they come and they're empowered, they're leaders, they're sim leaders within their college or university, and they go back and they need to be training other faculty. But at least they're getting the training, appropriate training, and they also build scenarios, debrief, we work together. It's one big happy family for 1 week in January, and then we meet quarterly to report out. Some are conducting research on the outcomes, and they become multi-site studies, not just one school study. And they've got network and friends across the state. So that's another partnership. Other changes, just the educator. No longer, of course we don't look like that anymore, but it's changing. I even say educators have changed from 5 years ago. Probably your new hires you're looking at to change, and you got to look at the new learners. Look at the millennials that's coming. I mean, they expect technology. They expect you not to be dumb in any of this, you know, and they want experiential learning. They want action. They don't want to be bored. They have high expectations, and just tell me, and they want to be good nurses or good RT or whatever. But our educators today, they're facilitators of learning because we do a lot of student-centered approach. We put a lot of onus on the students, but yet you got to facilitate. There's got to be some facilitation and learning going. Tech savvy, very real-world experiences. Students they want that. I know at Hopkins, people we employ, like our advanced practice folks, we allow them to practice 1 day a week or 2. They get 20–40% buyout. They bring in their practice money to offset their salary, but they're current. They're always current. They're bringing in, you know, talking about the patients they cared for last week in an anonymous way. You know what I mean? But they're there. And people are knowledge workers. They're creators, designers. If you've done online courses, you create this course, develop this module. Simulations, you got to be very creative. You're setting this up and using props and all that. So this was the bridge gap. I know there's concerns. People have told us over and over. And there was a survey done, just to very quickly tell you, in Washington, D.C., and this is how bad the practice gap is. If I ask all you educators in here, are your graduates ready for practice when you graduate? You probably just had graduation, what, in May? Or have you had graduation yet?
Convocation's coming next week. Where is
Next week. Okay, these graduates you're going to graduate, are they prepared for practice? And if I polled you, if we did a survey, technically probably 90% of you would say, yep, our students are ready for practice. I've prepared them, the curriculum's prepared them and all that. So then if we survey nurse managers on the clinical facility side, are those graduates prepared when you get them? Guess how many say yes? 10 to 11% only. So here we have educators saying 90% is prepared, and here in reality they say only about 11%. That's called the practice academic gap. That's huge. We've got to bring that together. And I think partly we've got to talk together. I liked being at the table with my hospital leaders. They need to hear what the school's doing. We need to know what the leaders at the hospital's doing. How can we work together? We shouldn't be replicating. Again, if simulations we're doing, they may want the same simulations for orientations. In the States, we're also looking at residency programs. Do you guys have those here for nurses? There's a big push now. The National Council State Board of Nursing has funded a multi-site study with 9 schools. In fact, if you Google NCSBN, National Council State Board of Nursing, you can read about this. But just like medicine, they have residencies, internships. But look at nursing. All of a sudden, they graduate, and we're supposed to know everything. And of course, we don't. And how would you expect that? But anyway, so now residencies are popping up, and hospitals are going to be accountable to have residencies. So then when they hire a new grad, they put the new grad in a residency program for 1 year. 1 year, and hospitals will pay for it. And it's like an orientation, but they're socializing them to the role. There's many residency type programs and curriculum out there. Again, I think if you Google that website I'm talking about, if you want me to connect you with any of that, I can as well. But that's big. And within those residency programs, there are simulations. They're counting on simulations to prepare those new grads at a better level. And there's competencies like at the first 3 months, competencies at 6 months, 9 months on, and determining and using simulations many times to test those competencies. So anyway, in that survey that I just quoted you with this practice gap, am I talking too fast? I get very excited and I'm looking, oh my gosh. Okay. Out of that survey came 6 practice-ready areas. This is where our practice people say, I want these new grads prepared in these 6 areas. That's where they're lacking, they need that. If you look at those 6, can you do this in simulations? Of course, all of them. Professionalism, communication, managing responsibilities. You can include all those readiness areas in SIM. My point made. Next steps, looking, I think looking back, we need to start incorporating these in all SIMs and tracking, just like patient safety competencies and all that. We need to be ready. The other, this is the nurse residency, and that's why I'm saying simulations are going to become important with residencies. This came out of the IOM Future Nursing Education report as well. So they were, this report from the think tank leaders and all that were saying, we're advocating for residencies for nurses when they graduate. And they're still going to be on the unit working, but they're in residence. So they're working just like a resident would be in medicine, but they have probably a diminished workload and their socialization and all that. And they have a preceptor. It's preceptor-based, which, by the way, that's probably going to cause a huge challenge for us because many times we use preceptor-based education, like in senior level, or we have dedicated education unit. You heard of those? That's preceptor-based. We assign our students to a preceptor. So the preceptors take the student, not the faculty. But now if many preceptors are going to be using these residency programs, that's going to be a challenge for us. So other key events, this is more national, international. I'll speak about those. This is a landmark that's called the National Council State Board of Nursing Study. If you would go on the website, you can Google and read more about it. So, but I'm just going to abbreviate it here. In fall 2011, so 2 years ago, 10 different schools, 5 community colleges, 5 baccalaureate programs. Some were private, some were large, some were urban, some were rural. We wanted to make sure the results were generalizable. And Johns Hopkins was one of the schools, so I know it dearly. I served as a consultant for the study to look at the research design and all that. I have not touched the data nor seen the evaluation. So what I'm going to tell you is just what I've seen faculty. And I would debrief with students overall just because I'm an academic affairs dean. I want to know what's working, what's not, and all that. So anyway, with this study, we are looking specifically at high doses of simulation. And is it harmful or not? Can we do it? In other words, can we substitute across courses up to 50% SIM and still be okay? Will our students still pass the NCLEX, the state board? Will our students still be a safe practitioner going out to the hospital? So this is what we did across 7 core clinical courses I just mentioned earlier. So in the fall, students were told about the study, and these were traditional baccalaureate students. So we informed, consented. Once they were in the study and they said, yeah, I want to be, they were randomly drawn out. Group 1 was the control. Less than 10% of SIMs were used to substitute for clinical. Less than 10. That was a traditional control model. Group 2, when they were pulled out, 25% SIMs would be substituted across 7 core clinical courses. So if we have 100 hours of SIMs, it would be 25 hours in the SIM lab, 75 in real time. And the ratio, by the way, is 1-to-1. And then we had a 50% group. So, and truthfully, in our curriculum, we have 112 clinical hours for one course. So it was really 58 hours in the real clinical, 58 hours in SIMs. So high dosing all through. So it wasn't just little pieces here, little pieces there. This is across all 7 courses over 2 years. And we just graduated those students in May. May 24th was their big graduation. Well, these are the study collaborators and all of that. It's run by Jennifer Hayden. She's at the National Council in Chicago. And I consulted along with Susie Carden-Egren and Nancy Spector. Nancy Spector, by the way, she's the one that's doing the study on the residency programs. So if anybody wants to know more about that, I can refer you to her. Anyway, we have phases. So phase 1, we did a survey. So partly when I said 87% of the schools of nursing were using SIMs, that's where part of that survey came. But also in the survey, we wanted to know what simulations should we be including. Up to 50% of pediatric, what does that look like? We just didn't want to randomly pull them and think, well, yeah, those are worthless. So we surveyed. So we surveyed pediatric faculty through INAXL, through the National Council site. So pediatric faculty came back and they said, these are the top 10 that you need. And then we rank ordered them and all that. So just give you an example, care of the acute respiratory distress infant. So we had a simulation on that because that was high ranking. So what happened across all 10 schools, we got all these simulations. So in pediatrics, we had like 20, 25 SIMs that we could use. And we didn't say do this one first week, this one second week. It had to match our curriculum. So if we were talking about respiratory airway in week 3, we did it week 3. South Carolina might have done it in week 5. Bottom line, we were substituting 0.5% of our clinical for SIMs or 25% or control. You following me? And across every school, they randomized their student into those 3 groups. Students had an opportunity, this was across 4 semesters, because we upper division curriculum with junior and senior. If they wanted to drop the study, they could drop the study. We would ask why they wanted to drop, and we note it as we followed for 2 years. Most hung together, I got to tell you. There's attrition, some quit. Some of it, I can just speak for Hopkins, and you'll read about it in reports. But sometimes it was a frivolous quit, meaning some student, they had to, and by the way, we tested clinical competency using a Creighton tool, and the clinical instructor checked that, and the clinical instructor came and watched the student in SIMS and looked at clinical competency. So the clinical instructor was always the evaluator for both. And all the SIMs were run by a SIM team that had been trained by the National Council. About 60 people across 10 schools were trained to ensure the integrity of the SIMs, that we were all conducting debriefing appropriately and running the SIMs in the way they should be. Are you still following me? So also to measure knowledge, we had the standardized testing. Have you heard of ATI and HESI and all that? We used ATI. ATI is a standardized test, so after psych, mental health, you take a test and you get a score. After OB, PEDS, they're all specific tests. And even at the end, they have an RN predictor. So at the end, when students graduate, they take this RN comprehensive. And you can see it kind of predicts if you get this score, you're more than likely going to be able to pass the state board. Many, many schools use that. So we measure knowledge, clinical competency, and all that. But anyway, I want to go back. A student, like one student dropped the study, she was actually in the control, but control is very important just as well as the 25 and 50%. And she just didn't want to go back to school on a Friday and do her ATI test. So I'm just going to drop the study. It was too inconvenient. So you had silly things like that. And there wasn't a high attrition, where another student I know said she was getting ready to go in OB her 3rd semester and was afraid she wouldn't see a live delivery, even though she was going to have half clinical hours and half, or maybe she's in the 25%, I can't remember. So she just thought in her mind she wasn't, which I'm in an urban area, Baltimore. These students see live births like multiple, many, but that was her, that was her prerogative. Phase 3, by the way, not to dwell on it, but these students have graduated. Now we're getting informed consent and going to follow them to clinical practice. This is that translation to practice. Are we making a difference? Are they better prepared? And a lot of those 50%, I again speak for Hopkins, they've got wonderful jobs. Many went into ICU, some went into an ED, and they feel very prepared. But they have been practicing the role as an RN for 2 years. For 2 years. They can manage. They got direct feedback every time. And the simulation scenarios are pretty phenomenal. And if anybody's in here, I don't know what areas you are, but I know psych and community health tend not to, people haven't done a lot with them. It's not right or wrong. There's not been commercial ones made, not that much. But if you want me to connect you with any of my faculty that did psych, community health, OB, peds, I will share that with you. I'll connect you, but because they've got some really nice sims, we've got some outcomes and all that. Does that make sense? So research questions about clinical competency, knowledge, and then we're going to track and look at orientation time, look at comfort level, look at competencies on that. So the other thing I briefly, and trying to summarize, finish up here, Society and Simulation in Healthcare. Has anybody heard of SSH? If not, you can Google that. That's a whole organization that's interprofessional, interdisciplinary, and that's about simulation. The sim gurus are in here. I like it. It's like, I like it because of the interdisciplinary, interprofessional, and lots of nurses are in that. But if you Google SSH, there's a research, we had a research consensus conference. There's 11 monographs on these topics. The research has been synthesized, analyzed, and I think those monographs are priceless. So if you want to study more on debriefing, I want you to be able to pull these down. They're free to you. Just wanted you to be aware. And if you're not a member of the society, you might think about it just because you get a free journal, well, you pay it with your membership dues, but there is a nice journal and listserv, and every January we have a conference. So, and SS certification, that started through the society. So now people, and there are over 200 people certified. It's a basic certification, and there's a process you go through. But if you're a sim director, sim guru, you've been doing it, you can take an exam and now be certified through SSH because you know this. So if you look at their website, there's certification category. These are areas they're going to test and all that. But you can see the blueprint of the exam, and it's a computer-based exam. But people are very successful. We've got over 250 certified. Lastly, not lastly, but another point is also through the society, SIM centers are becoming accredited. So you can go through this accreditation process and have this seal of approval and all that. So I only bring this to you because there's so much going on in simulations. Unbelievable. INAXL, that conference is next week, but they're developing standards for simulations. So if you want to know about the role of the facilitator in SIMS or about professional integrity, there's standards written. So now we finally are getting some consistency with standards where we didn't before. So that's, if you Google INAXL, INACSL, you'll find all that. And another point I just want to make, high-stakes sim. And again, we can talk more after lunch. I feel like I'm getting rushed here at the end because I know we have lunch. But National League for Nursing, they realize that many schools in nursing, right or wrong, I'm the messenger, I'm just saying, some schools in nursing are doing high stakes, meaning students can't graduate until, I'll give you an example, until students take that HESI test or ATI test and score, say, a 900. So some of these students are taking that test 5 different times until they get the 900. Then they get their diploma and pass. That's high stakes. HESI's getting some money. Students are frustrated. We're not getting them out there to practice, and then more likely they'll pass their boards. But anyway, sometimes people are doing high stakes sims. They put them in a simulation, and maybe it's not well developed. Maybe the evaluation tools don't match the simulation. So we're hearing some about that in the States. So what NLN, through their foundation, they have developed 4 high-stakes simulations, and I've been working with the authors to develop them. One's on teamwork, one's on assessment, one's on safety, and there's a 4th one I can't remember. But they're either going to be free or very cheap, and they're just been tested, they've been peer reviewed and tested, and they're going to give you evaluation tools for them. Because so part of the challenge with educators is we might want to do SIM, but how are you going to evaluate it? Where's the tool? And you got to go make up a tool, and it might not match what you're doing. So that's forthcoming. So I wanted to alert you to that. And again, I bring you attention. I think it won't be long because this demonstrate competencies where we might have high stakes testing too for new grads. I'm just saying, I think that's handwriting on the wall. And IPE, I'll talk more about after lunch, but you as Canadians have a big, America's always looking at your literature in Canada and doing that. You guys are way ahead of us, so we'll talk more about that later. And simulations in healthcare, they're just, programs are going. Now we're at the point where more research is needed. What's the value added? And that value is, over with the patient outcomes. And also, are we making a difference in learning behaviors and outcomes with our students? So future, it's bright, lots going on. Future possibilities, expanding it in education, evolutionizing with the SIM technology. I know now at Hopkins I'm working, I actually gave a percent workload to one of our tech people. We call her the emerging technology manager, but she's looking at apps and devices and iPads and how to bring that in. We're doing telehealth through an iPad, and it's a simulation, but they use the iPad to connect. And we're trying to bring all those technologies in too to be innovative and actually crank it up a notch. So hopefully future possibilities that we're going to prepare better graduates. So what we're all about, of course, doesn't matter where we are, what country, what school, what discipline, it's all about optimal student learning for high quality patient care. So I'm looking at the time. I think I've run out. But I hope you've written your questions. I'm going to look at Marlene because we can start with questions and I can insert because I hate not ending. Sorry, I included way too many slides, but I felt like I had to tell you this stuff. Aren't I just like a teacher?
But we still
I feel like I have
the
to tell
slides.
you.
We still have the slides. So then we come back after lunch, and I would let this go, but there might be even something hot over there.
Yeah.
So if we want it hot. So I thank you for this real beginning. I can just imagine the chatter over lunch. So lunch is right across.